Ladies and gentlemen, welcome back after the Jummah break. To begin this landmark session on a spiritual note, we will now start with the recitation from the Holy Quran.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم إنا أعطيناك الكوثر فصل لربك وانحر إن شانئك هو الأبتر.
Ladies and gentlemen, Assalamu alaikum. My name is Zalina Ali. I'm a fourth-year medical student from Rashid Latif Medical College.
And my name is Mishal Khan. I'm also a fourth-year medical student from Rashid Latif Medical College.
We hope everyone is feeling refreshed and re-energized as we now gather for what promises to be one of the most remarkable highlights of 28th Annual International PSR Conference. It gives us immense pleasure to commence the short pediatric course, a session specially curated for family physicians, pediatricians, and adult rheumatologists alike. This initiative stands as a milestone moment in Pakistan's rheumatology landscape, as it is being held for the very first time in the country under the esteemed patronage of APLAR.
Before we begin, we'd like to go over a few rules. Please make sure that your mobile phones are switched off silent, and please maintain conference decorum. A Q&A session will follow the talks. Attendees are requested to obtain Q&A cards from the ushers and write concise and relevant questions and pass them on to the chairs via the ushers. Now, to formally commence this landmark session, it is our privilege to invite a pioneering figure in Pakistan's pediatric rheumatology community, Professor Sumaira Farman Raja, Professor of Rheumatology, Co-Chair of the ACF, and Head of Department of Rheumatology at the National Hospital. Professor Sumaira's visionary leadership and unwavering commitment to pediatric rheumatology have not only been instrumental in shaping the scientific direction of PSR 2025, but have also played a pivotal role in advancing pediatric rheumatology education across the country. Ma'am, we are truly honored to have you with us today. May I now request Professor Sumaira to kindly come forward and deliver the welcome note for the short pediatrics course under the patronage of APLAR.
Thank you so much. Assalamu alaikum. I'm hoping that lunch jaldi se khatam ho so that more of you can come. I would like to say Assalamu alaikum to all of you. Special welcome and salam to Professor Sajid Maqbool, who's been a pioneer in pediatrics in Lahore and has been one of my mentors as well. Professor Masood Sadiq, the Vice Chancellor of Children's Hospital, and Professor Shahid, who's the Professor of Pediatrics in Lahore General Hospital. Special welcome to my mentor, Professor Nighat Mir, to Professor Ahmed, the convener, who has managed to arrange everything so beautifully. And I can see Professor Chris Denton, so what an honor that you are here today. Before we say anything else, because some of our guests have to leave, I just wanted to give a shield of thanks to our special guests. So Professor Sajid Maqbool, if we may just give it to you now and then we can proceed with the course. So Professor Sajid Maqbool. Niche le jaओ, Sajid Maqbool. Huh? Professor Nighat, can you please come up? So quickly, let me just tell you a little bit about pediatric rheumatology. Pakistan population is touching 260 million. At least 40-45% of our population is 14 and under, so we have a huge young population. We know that you need pediatric rheumatologists at least. When we look at the ideal and the average required, we need anything from 400 to 800 pediatric rheumatologists for Pakistan. And you know that there are just a handful of us adult rheumatologists who've done some training and certification, and handful of pediatricians who are doing the same. So we really need to spread the word, because these are potentially disabling diseases and they should be diagnosed early so they can be controlled. So thank you very much. Professor Sajid Maqbool, please. May I now request Professor Masood Sadiq, the Vice Chancellor of Children's Hospital, who's been very kind to take time out for us today. He's a pediatric cardiologist and he's a big support to pediatric rheumatology as well. So Professor Masood Sadiq will just make a few comments.
Thank you. Thank you very much for the kind invitation. I think we are extremely grateful to the Society of Rheumatology and all the pioneers in rheumatology. Let me share with you that College of Physician Surgeons Pakistan, because I currently head the Faculty of Pediatrics at CPSP, we in our meeting last week has formally approved fellowship in pediatric rheumatology. And I thought that was something to share with everybody, and we look forward to the support of adult rheumatology colleagues in terms of development of the curriculum and, of course, initiation of the fellowship. And University of Child Health Sciences Children's Hospital already has a section of pediatric rheumatology, and we really are extremely thankful to all the honorable adult cardiologists who have been really at the forefront in terms of supporting us. Thank you very much, and thank you for the invitation today as well.
Thank you so much, Professor. And I'd like to request Dr. Professor Shahid for Nigat. Can you come back? Yeah, niche aajo. Exercise, cardio. Ahmed. Thank you so much. So Lahore General Hospital has actually initiated a pediatric rheumatology outpatient last month, and they have invited me to come there to see the patient. Thank you so much. So Professor Gondal will come at the end for the closing ceremony, and Professor Shaida Khwaja will also come for the closing ceremony. Professor Tahir Masood also, we're expecting, hopefully he's going to be coming soon. Yeah. So I think without further ado, we're going to start with the first talk, which is going to be handed over. Yeah. So I'm going to hand over to the stage ushers to proceed with the program.
Our first speaker for the short pediatrics course is Professor Tash Arkachaisri, professor at Duke NUS Medical School, director of the APLAR Center of Excellence, and senior consultant and head of rheumatology and immunology at KK Women and Children's Hospital. Today, he will be presenting on arthritis in young people, adolescents and children, overview, types, and management. Please join me in warmly welcoming him to the stage.
Okay, the whole pediatric course section is after lunchtime, so I hope that no one's sleeping. Otherwise, I will get you up anyway. So it's my privilege to be here, and then this morning I have seen many patients that has been treated quite well and actually doing well. That's actually changed the life. And then it reminds me about 25 years ago when I first started pediatric rheumatology in Thailand. The situation is the same. Okay, now I move to Singapore. Okay, let's get to the talk. Now I have 30 minutes, and then I believe that there's no timer, right? So need to remind me if it's 5 minutes, otherwise I will use longer. Okay, so kick off with the juvenile arthritis, and then the audience are pediatricians and adult rheumatologists, so it's quite mixed. So if it's too boring for adult rheumatologists, you just have to bear with it. Okay, I won't go into detail much. And the past 12 months, I don't have any financial relationship. And then I will discuss off-label investigational use, actually majority of them. Okay, and this is my agenda to go through in the next 30 minutes. If we have time, then I will say some update on these topics. So first thing first is a classification. Since 1977 all the way to 2019, the Printo is the last organization that tried to change the classification. It just indirectly tells you that our existing classification is still not perfect. And I wrote down here, the classification system is not for you to really grab on it. It just serves as a guide to tell your patient what they have and then make guide treatment. And some of them actually confer the prognosis of the disease. So, each guideline is trying to homogenize the subtypes as much as possible. Okay, and Printo 2019 come up with another 4 subtypes, and I will get through that if we have time. Okay, at the moment it's still APLAR classification criteria, which classify the JIA into 7 subtypes that we still using both in clinical setting and in research. Yeah, so the group that we have problem with is this rheumatoid factor negative that is not quite homogeneous. And then I will talk more about that later on. Okay. And then this group also never found in the adult. This is still stay at the same early onset ANA positive. Okay. But it's this group that has some heterogeneity there. Okay. So I just gonna go to this real quick. Everyone must have the onset 16 younger than 16 years old, and 16 years old is not the lottery slot or anything. It's just something for you to grab on. I believe that later on the age cutoff may go all the way to 18 even. The printer already cut off at 18. Okay, systemic arthritis is still the same, and this equal to the adult onset still disease. And according to the international agreement and guideline, we will use the same name as still disease. Okay, oligoarthritis. All these are classification within the first 6 months. Okay, of the disease. So oligoarticular type. The number of the joint is 4 joints or less, and then there will be 2 subtypes in the oligo. One is the oligo persistent, meaning regardless when you look at it, even after the first 6 months, you still have 4 joints or less. Extended is after 6 months, you have more than 4 joints, and these usually involve the small joint of the hand or the medium joint of the wrist or ankle. Okay, polyarthritis use rheumatoid factor to classify whether it's negative or positive, as I mentioned about this group. Now you also have to remember the exclusion in order to be more homogenized. Then we take away those that we know. Psoriasis or a history of psoriasis in the first degree relative, regardless of what you will not classify. Okay. Arthritis, the B1 is arthritis with HLA-B27 positive beginning after the 6th birthday. Okay, so female with B27 positive is not the exclusion. Okay, and then this one is HLA-B27 positive related disease in the first degree relative. And then the next one would be IgM rheumatoid factors used to classify, and then the presence of the systemic features in systemic arthritis cannot be present there. Okay. The next group is psoriatic arthritis. So kids can have arthritis 10 to 15 years even before the skin lesion occur. So we need to have other helping, and they are usually quite young and female predominates. As long as you have 2 out of 3, then you can be classified as such. The first one is dactylitis, second one is pitting nail, the third one is the first degree relative psoriasis in the family history. Enthesitis related arthritis, as you know, this is almost equal to your adult spondyloarthropathies that I may mention later. So you have arthritis and enthesitis, or if you don't have enthesitis, then you need 2 out of these 5 to classify. And then undifferentiated, meaning you fulfill more than one or you don't fulfill at all. And this varies according to the ethnicity and geographic area. So this actually, when I first graduated in the year 2000, went back to Thailand, and this is my first one. So oligoarticular type is the most common subtype, occur up to 50 to 60% of the Western JIA subtypes. But that does not apply to the Asian population. I will give you the distribution later. But let's get to the point first. So they're usually small, younger than 6 years old, female more than male. And then there's the one that the joint prognosis is quite good. They usually don't get disability. But then the eye prognosis is the worst because they have a higher chance to get chronic uveitis that can lead to blindness if you don't detect and treat early. And it has to be, it actually the one that the uveitis subtypes, uveitis type that is very recalcitrant to treatment according to our pediatric ophthalmologists as well. Okay. So they usually don't cry with pain much. Even though they have swollen knee like this, they still can run around most of the time. And the knee is the most common joint affected, up to 80% of the time. Okay, as I mentioned, if after 6 months they have more than 4 joints, then they will be classified as extended oligo. The behavior would go into someone like your rheumatoid factor negative rheumatoid arthritis like that. Okay, so this go to the polyarthritis. As I mentioned, we use rheumatoid factor IgM to classify. So it's into 2 groups. The first group is rheumatoid factor positive, which reflect in this peak, female more than male. And the arthritis, like rheumatoid arthritis in adult, quite progressive and destructive. Raised risk for the eye disease, but bad prognosis for the joint disease. Okay. And I will show you later about the outcome. They are the one that less likely to be off medicine. Okay. Another group, this is still quite heterogeneous. This is this peak, actually. So it's younger than 6 years old, still girl more than boy. And then the first group is, well, I actually mentioned about the younger one first. The younger one is less than 6 years old and they're usually positive. And then asymmetrical joint involvement, unlike the rheumatoid factor positive, that mimic the adult RA. Okay, so this group behave like the oligoarticular GIA, that they have ANA positive, so the risk of chronic uveitis is higher as compared to this one has lower risk. So I will not have time for the screening. So the one that has medium risk, you screen for every 6 months. The one with high risk, usually younger one and female and ANA positive, you do every 3 months for the first 4 years, and then every 6 months for the next 3 years. Uveitis usually happen the first 7 years after onset. After that, it's usually less likely. So you may be relaxing on your slit lamp uveitis screening. Okay. And this morning, I see some of your systemic onset. This is my 2. They are not couple. They are just the first patient and the first 2 patients that I see when I went back to Thailand. All these are not the muscle. These are all synovial hypertrophy there. And the big belly here is hepatosplenomegaly. So this is the one. And then systemic onset run like adult, male and female is equally distributed. Okay. The hallmark would be you have quotidian or intermittent fever, meaning the number 1, the peak and the trough more than 1 degree centigrade. And then the trough of the temperature touch or below baseline. Okay. And the temperature usually more than 39. Okay. Yeah, so 10% of them can have light-threatening macrophage activation syndrome. There are 2 phenotypes that you can classify up front. One is more of the auto-inflammatory phenotypes, where they don't have much arthritis, but they have arthralgia, together with high fever, RE system activation with generalized lymphadenopathy or hepatosplenomegaly, and then sinusitis. About 30% if you use the imaging to detect, usually asymptomatic. Okay. Another group would be the arthritis phenotypes, usually poly and usually symmetrical, and it's quite sometimes progressive like RA. They can erode your joint quite fast. This is the group systemic onset that can have other organs involvement. I put in a small one because it's not common. Okay. Now next one is the enthesitis, related arthritis. The one that you have arthritis plus enthesitis, then you can classify, or if you don't have enthesitis, then you have to use 2 out of 5 of those areas. And this encompasses all of your HLA-B27 related arthritis in adult. So This is just the adult rheumatologists here probably see more than us, and they do the same. Rheumatoid arthritis, they usually erode your joint, but this group of the patient, when they have chronic arthritis and not well controlled or enthesitis, they pop up more bone. So this is bone spur from the plantar fasciitis in one of the patient. Okay, and then this is psoriatic arthritis. As I mentioned, dactylitis is like sausage finger there because they have some flavor of the tenosynovitis, and usually young and girl. And then many times you can see the nail pitting. Okay, prognosis is still like adult psoriatic arthritis. And this is what I want you to pay attention. Asia Pacific is quite a big area, and then with different ethnicity and different geographic area and different culture. So everything that distribute here in the West, you cannot use it. So you have to use your own country distribution in trying to tell you what you would see, and that actually dictate your health subsidized policy in your government. Okay, so if you want to see systemic onset, then you go to Japan and China. Thailand and Malaysia has 1/3. Okay, China has almost 50%. I think part of it is probably referral bias because they come with high fever, and you know Chinese cannot stand fever, so they run to the hospital quick. Okay. Middle Eastern distribution is more or less close to the West. Okay, and then I want to highlight the enthesitis related, the one that associated with HLA-B27. If you want to find them, you go to Singapore, you go to Taiwan, and then you also go to North India. Okay. Another thing that we pick up when we report is the incidence of the uveitis in Asia Pacific is not the problem. In the West, if you look at the number, it's almost always 25 to 35%, or almost a third of the GIA population that will run into chronic uveitis. But when you go to Asia Pacific, it's less than 5%. So the screening, how frequent to do it, we need to modify according to our own area. And that also reflects the number of the ANA positive is less common as compared to the West. Okay, now this is what I can find from Pakistan. Or for some reason, Lahore has 3 reports. What I want to highlight is you don't have much of the oligoarthritis, but the one that you have is the polyarthritis. Okay, I couldn't find whether it's more rheumatoid factor positive or negative. My gut feeling is probably rheumatoid factor negative. Okay, so this is your patient that you're gonna see more than anything, almost half of the patient that you're gonna see. Fortunately, that you do not see many of the systemic onset. It's about 10% live report in the West. And then the next one would be the oligoarthritis. The ERA is only single digit. So I don't know how many of you ankylosing spondylitis here, but at least childhood onset, you don't have that many. Okay. Okay, that's what I already said. Now we go to management. I don't want you to hook up with the classification much, but you should stick to it because that's kind of like a guide you for the treatment that I will say later on. Management, and this is the ideal rheumatology care. I steal this slide from Chris Scott, who already moved to Ottawa, Canada. So early recognition almost always, and we already know that if you control the arthritis within the first 6 months, response later on will be better, and the long-term outcome also better. But if you pass that, then it will be a lot of complication along with joint deformity or disability later on, regardless how much that you can pour in. Okay, so if you can, you refer. Otherwise, you may need to do something. And then because this is the decade of the treat to target, and the treat to target has been identified in many other diseases, including adult RA, that just by doing treat to target itself, regardless of what regimen that you use, the outcome is actually better compared to the non-treat to target way in the old ways. Okay. So in the region, because we have 17 out of 51 countries that has pediatric rheumatology well-trained subspecialty. So 70% of them still see non-pediatric rheumatologists, and half of them will end up in your clinic, which is adult rheumatology clinic. So And majority, another half would go to see pediatrician or even family practitioner, general practitioner, or even nurse that may need to see, or even in some country, OT and PT need to see them. So we need our own guideline to guide treatment that is less for you to choose, but tell you exactly what to do and how to do it, and how long you need to do that, and when to change treatment, that kind of thing. So in the region, we are up to this point that we are generating the APLAR consensus recommendation for the management. Okay, and management, because there are extra-articular manifestation, then you need many people, many subspecialty in your area to have the holistic management. Okay, now this is a principle of treatment. The first thing first, because inflammation causes pain and disability. So you first thing, you stop inflammation. That will be done by anti-inflammatory and DMARDs. And that already decrease your pain and discomfort. So you can send your kid to school. This morning I see one boy that hasn't been to school for years. And that is just, the time never fly back. Many of us, almost 60 or even beyond that, you know already that our age, our time is not coming back. So kids is different because each age period, they have to go through the psychological, physical, both gross motor or fine motor development. Once you pass that, for example, if the kid has arthritis and cannot walk normal before 5 years old, even you treat them, after that they will never walk normal again. So they cannot become actors or even model in that matters. So you want to get rid of that as fast as possible. And once you can control the inflammation, then you start to preserve the function. If they have contracture, then you do stretching exercise, you do sprinting in order to regain the joint function by physical therapy. And if it's small joint, then occupational therapy will also do the sprinting for them. And then long-term wise, you want to maximize their growth potential and development potential, and also prevent deformity. Another one, big one is you want to minimize the long-term side effect of the medicine. Philosophy is like this: patient already have one problem. You don't want to give another problem with a long-term side effect. Okay, so as I mentioned, JIA is still the burden in our region, and we cannot reach for biologics and JAK inhibitor. So our guideline will still pay more attention to the conventional synthetic DMARD. And then it has been shown by the KERA group, which is the US multi-center group, that monotherapy with biologics, when you start biologics first, and monotherapy is not doing anything different than you do step up, meaning you start conventional DMARD and then you add biologic later if the patient is not responding in the time that you want, which usually 3 months. Okay, so I'm not going to have you try to wear the glass to see it, but I just want to point out that this is for active arthritis, first diagnosed. You look first whether they have high-risk joint or not. High-risk joint means the joint that may give you a long-term problem, and the joint that may be problematic in terms of response to conventional medicine, or the joint that you need to take care, otherwise that will be bad. And this includes cervical spine, include hip joint, include wrist joint, and also if you already have existing joint damage, you will try your best to use conventional DMARD plus something. Okay, so if you don't have the high risk, you go with sub-Q methotrexate. If you have high risk, if you can find it, anti-TNF you can use. Now I just learned that you have JAK similar here. So you can put it in, because network meta-analysis already show that different types of TNF or non-TNF biologics compared to the JAK inhibitor efficacy is not that different. Okay, so if JAK inhibitor you can reach, you go ahead and do that, because combination is still better. Now the reason for the combination again is nowadays we know that the biologics actually make rheumatologists quite happy, as we can see 100% no arthritis and no disability. But then when you use later on, you will start to see secondary failure, meaning it used to work, but then it's not working anymore. And anti-drug antibody is the main cause part of it. So using MTX concurrently decrease the risk at least by 2/3 already. So it made you be able to use anti-TNF a little bit longer instead of losing it, because regardless where you go, if you're going to get biologics, anti-TNF would be your first one. And it happened to be the cheapest one also. And now we have biosimilar. So you would want to do that. Okay, and this period is take only 3 months. Before that, you can use steroid or NSAID, depend on the severity of the patient. If the patient is very disabled, cannot walk or use cane or any walking aids, you may want to use glucocorticoid. And we already show you that the pulse steroid and the 2 per kilo or less oral steroid does not work any difference. You don't need to do the pulse, waste your time. You just give 1 to 2 per kilos and see. And this is called bridging therapy. We want you to stop by 3 months if you can. Okay, if a little bit less, then you can use NSAID. Okay, and then they can have less pain, and then they can go on with their schooling. Okay, and then if this is still not working, if you start MTX alone and it's still not working by 3 months, then you go to add the anti-TNF. Okay, if you already add it, then you have to do something else, and these are a little bit tricky because it always involves the accessibility of your medication. So if you have primary failure, meaning you use anti-TNF and it's never worked, it's called primary failure. We always tell you this is strong recommendation that you don't need to try the TNF. You have to switch the class to non-TNF or JAK inhibitor in that matters. Why do we do this? Because I believe that in the region, the patient come to you is quite late already. You don't have much time to play with it because disability is already threatening at your doorstep. Okay. So this is just for the police. Okay. Then monitoring of the disease, the C-JADAS, clinical JADAS is like DAS 28 in adult, but we use JADAS and then we use only 10. 10 is a maximum. So if you have 15 joy, it's still 10. So it has been shown to correlate with JADAS 71 joy or 28 joys. Actually, in a BC clinic, you can use just that. And it composed of 3 components only. Number 1 is the active joy. And if it's more than 10, it's still 10. Number 2 is physician global assessment. Number 3 is your patient global assessment. So you only have to work on your patient global assessment. And everything is 10, 10, 10. Maximum is 30. Okay, so that will guide your treatment. Okay, and then for the X-ray, I'm not going to mention. So depend on the accessibility and then the patient preference. But in a high-risk joint, you want to know your baseline. And then the first year, you may want to repeat it because we know that that was in the adult, in the West Italian study. They know that if your joint going to be erosion happen or damage, it usually happen in the first year. So that's why we want you to look at, because if you have joint damage, you need to hurry and up or escalate your treatment a little bit sooner. Okay, and physical therapy become our strong recommendation. Regardless of the stage of the treatment, you should involve PT/OT. In the acute stage, they can help with your physical means like the cold or the heat that may help in different situations. And then when they get into control, no pain, then more of the preserve function. Okay, and I'm not going to mention about the traditional and complementary medicine, but you will never use it as a sole monotherapy. And this is almost always adjunct. And the one that we see that it may not, it may be helpful, it would be the stretching exercise like yoga or the massage therapy. And this is done by their parents, not anyone else. And it should be done by the trained professional. Okay, not any time that we recommend any diet over there. Okay, for the temporomandibular joint arthritis, we start to learn this about 10 years ago. And at this moment, we still do not know how to handle it much. So the management is more or less mimic the polyarticular JIA, for which NSAID, you don't need to waste your time because on my hand and other colleagues, it's never enough. So you go ahead with your MTX, methotrexate, which is our recommended first conventional synthetic DMARD. Why methotrexate? Number one, because we know them for almost century. And in pediatric rheumatology, they are the first one. We know how to handle them very well. And then there are tons of data that support the use of it compared to leflunomide, compared to sulfasalazine, compared to hydroxychloroquine. That is less. Unless you have no choice, you may have to look into those conventional DMARD. The dose is another one. Leflunomide, you cannot use in young people because there's no dosing there. Okay, so again, you can use a steroid as bridging therapy, and both of them you can use intra-articular corticosteroid. But for TMJ, people reluctant to use it because it may the chance of intra-articular calcification seem to be higher. Nerve injury is quite there. And then not only that, repeated injection may have some effect in terms of the long-term growth of your mandible. So that's what we need to worry. You should not have it done more than 2 per year if you need to do it. So rheumatologists, we usually don't do it. I have done a few only, and then I just shy away because we have biologics on hand. And this is for the osteoarthritis. This is the easiest one. There are 2 schools in the US. This is from the ACR because our guideline hasn't come, but it probably may make the same. First thing first, if you love to inject it, you just inject steroid. And if it's work, it's work. And for the knee joint, it's up to 90% is work. And then if you use the hexacetonide instead of acetonide, it can last up to 4 to 6 months compared to acetonide. Number one, you need to use double dose. Number two, every maybe after 2 months, it will be gone. So this is some kind of good bridging. Instead of using systemic steroid, you just use this because the kids already have 1 or 2 joint, and usually I told you it's the knee joint, so it's easy. Or another school that does not like to do it, then you try NSAID. If NSAID does not work, then you need to go to conventional synthetic DMARD, and almost always methotrexate is first. Then you go, it's exactly like the polyarthritis group. Okay, this group usually quite okay. We hardly have any problem. Okay, so this is for sacroiliitis. And if you look at it, it's more or less like adult ankylosing spondylitis who has axial skeletal involvement. We already know that methotrexate does not work. In our data, when many of the country for pediatrics, in order to get government subsidy for biologics, you need to demonstrate that they failed methotrexate before. So when I first go back to Thailand or even Singapore, the first 10 years, we already know that if peripheral joint involvement and you use good dose methotrexate, we will never use dose less than 10 to 15 milligram per meter square. If you use less than that, it's not working. And that has been done since 1999, New England Journal publication. The Russian people actually do it, randomized control. You have to use more, and preferably subcutaneous injection if you use more than 15 milligram per meter square, and that to improve the absorption. Okay, and since we don't have that many choice, so you may want to maximize it. Okay, so we get our own data. If you have the peripheral joint involvement up to 85%, actually it's working. But once you touch the enthesitis or sacroiliitis, only 15% that is working. So it's like a flip of the number. So when they have sacroiliitis, I hate to say you need to use biologics. Which anti-TNF would be your first choice now? I just pick on your drug booth over there. Even upadacitinib, I think you have JAK similar. So you can use that. If that's cheaper and is nice, if you want to enhance compliance in the high-risk group of the patient, start JAK inhibitor right away when they have axial involvement, because this one have something to do with your spine, and the disease almost always go on to the adult. You don't want to give the adult counterpart, adult colleagues, some ankylosis. Okay, I think my time is getting there. Okay, so this is just summarize what I said. Like exactly adult, you don't need to do anything, and then inject the steroid. If you can do, you do it. I cannot do it, and it's very painful after injection. So I usually do oral as a bridging. Okay, and then physical therapy is there. Enthesitis, treat like sacroiliitis. Okay, same thing because MTX not working. And then a systemic onset This is tricky. I'm not going to say anything much because we haven't come up with the APLAR consensus guideline yet. Probably next year, so you can read it in any publication. If you have access to IL-1 or IL-6 inhibitor, then you do so. But I believe that you don't, because even in Singapore we don't. Okay, so you may end up with the conventional synthetic DMARD. And every single time before you say that it's not working, you give a good 3 months. Every single DMARD, including conventional synthetic or biologics or JAK inhibitor, if you look at the clinical trial, even in adult, it usually takes about 12 weeks before it's reached plateau, meaning if it's worked, it worked before that. After that 3 months, if it's not working, you can quit and escalate your treatment. Okay. Outcome. These are the predictor of the bad outcome. Diagnostic delay lead to delay treatment is there. And then once you grab the patient, you have 6 months to fix them. Okay. Another one would be everyone know RA, rheumatoid factors. Okay. And these are the high risk joint that I did mention. Okay. I want to show you just to scare you. Even this, you look at this, these are all after 2000 when we have anti-TNF or non-TNF biologics. The damage in the Asia Pacific region, and this from India, from Thailand, and also India, articular damage is 30 to 50%. Compared to the West, it's actually less than 15%. So we still have a long way to go to do that. Okay, extra-articular damage is at least a third compared to like 10% of that. Okay, and then I don't need to talk about growth failure. When you have generalized arthritis, patient won't grow. And when you use steroid, they don't grow either. And this is just a Singapore. You don't need to say anything because at this cohort, I use biologics only 30%. So that is mimic like anyone in Asia Pacific. You already know that RF negative, less likely that they will be on remission without medication. They will be on some kind of medicine off and on, not more than 12 months. Every other group, they do that. But your polyarthritis, whether rheumatoid factor positive somewhere, this is positive. The negative one, a subgroup will do that, only 15%. Other than that, they enjoy good inactive disease with pain-free. Okay? And then this just to tell you, if you use about 30% of your cohort, meaning that you do the step-up therapy. Okay, within 6 months, you see 6 months total, about 40% you get into inactive disease already. And then you look at the polyarthritis, 40% rheumatoid factor negative. Well, compared to the rheumatoid factor positive, only 10%. Okay, so this is just to tell you that we can achieve what the West has been achieving as long as you treat to target and escalate your treatment faster. Use steroid. There are many ways to use steroid. Okay, my time is done, right? I'm done. Okay, 2 minutes. We did the meta-analysis to convince you that biologic adalimumab biosimilar safety and efficacy is the same as original. Feel free to use. And then when the patient gets into inactive disease, you want 6 months of inactive disease before you start weaning. I just gonna show you that this is for adalimumab. Short weaning and long weaning does not change anything. It does not change the rate of flare and the time to flare. You're gonna flare 50% at 7 months, whether you use short or long. And then if you're gonna drag it through, the long one does not want to stop it. You can go up to every 8 weeks because that when the patient that wean, that flare during weaning is when they are in every 8 weeks. So if you all the time do every 6 weeks, you're still gonna be okay. Okay, I think I can stop here. Well, I don't have time, but I just gonna convince you the new classification is not working. They still have a lot of way to do. And then we try to match to the adult. Only a third of GIA, regardless whether you use printer or you use APLAR criteria, will send you exactly there. Only a third that match adult disease. Another 60-something% still not doing it. Okay, that's it. So this you just read, that's my summary. Thank you.
Thank you for that enlightening presentation. I would now like to welcome Dr. Muhammad Shahid, a renowned and well-respected name in his field, along with Dr. Taktis Khalik, consultant rheumatologist at the Federal Government Polyclinic Hospital, Islamabad, Pakistan, as chairpersons for Session 1 of the Paediatric Rheumatology Course. May I now request our esteemed chairs to kindly come forward and lead this opening session. Our next speaker for the short pediatrics course is Dr. Elizabeth Ang, Senior Consultant in the Division of Pediatric Allergy, Immunology, and Rheumatology at Khu Tech Puat National University Children's Medical Institute, National University Hospital, Singapore. Today, she will be presenting a case-based discussion on management of mass HLH and difficult juvenile idiopathic arthritis. Please join me in warmly welcoming her to the stage.
Good afternoon. Good afternoon, everyone. Thank you so much for the honor of being here with you today. I hope in the next 30 minutes, I will present a practical approach to patients that you may see, whether in the outpatient or inpatient clinic with MAS or HLH, and then I will also be discussing some difficult JIA practical pointers. This is the outline of the first part of my talk. Let's start with a case. A 9-year-old girl with 2 weeks of fever, rash, very definite arthritis, splenomegaly, and generalized lymphadenopathy. And at the bottom of her slide, I present her CBC, ESR, CRP, and liver function. This is a typical case of a child with a prolonged fever, rash, joint pain, and that brings to mind many differential diagnoses. I hope that for you, the top 3 would be malignancy-related, systemic JIA, and maybe for some of you, you're thinking about HLH. Great. This is a pretty typical history and physical exam for a girl with systemic onset JIA. She has the fever, the rash, the arthritis, but there's something atypical about her, and I hope you're thinking about that. For a girl who has been very inflamed for the last 2 weeks, she has an unexpectedly low white blood cell count and an unexpectedly low platelet count of 10 lakhs. Her hemoglobin is what you would expect for someone who is chronically or long-term inflamed. With these atypical features, these 2 things should come to mind, either a bone marrow malignancy or HLH. For her, she underwent a bone marrow examination which showed no blasts, and what was very helpful was an extremely elevated ferritin of 16,000. So her diagnosis was systemic JIA with macrophage activation syndrome, MAS, also known as secondary HLH. Let me present another girl who was 11 at the time of presentation. And she came to me in February, but with 3 months of being unwell with a retroauricular lymph node. Her test done in another country in January was reported as inflammatory. By the time she came to me in February, she had a rash, a very high fever, not just a retroauricular lymph node, but generalized lymphadenopathy. And she was advised by her doctors in the other country to do a bone marrow aspirate. But the parents were very afraid about this test and came to Singapore. On exam, she had hepatomegaly, generalized lymphadenopathy in the cervical and inguinal lymph nodes, no arthritis, but she had a rash, and this is what her rash looked like. Some papules on the nose and the cheeks, erythema on the palate that was not painful, and these vasculitic lesions on her hands. I hope you're thinking about some autoimmune condition. Here were her investigations showing a pancytopenia. The low complement, positive ANA, pointed heavily to the diagnosis of SLE. Indeed, she does satisfy criteria for SLE, but again, there's something atypical about her. She's extremely pancytopenic, a little bit more than I would expect for someone with lupus. And her ferritin was high at 3,000. Her diagnosis was SLE with MAS. So really, what's in a name? MAS, HLH, secondary HLH, cytokine release syndrome, sepsis, and in the last few years, COVID with multi-system inflammatory syndrome. Well, if I were to present to you the historical view of HLH, we would think of it in terms of primary and secondary HLH. When we think of primary HLH, we think of a monogenic disease with a fixed cytolytic defect. The patients are usually young. The triggers are not easily identifiable. Untreated, they may have recurrent episodes of inflammation, and potentially this is fatal. The treatment for primary HLH is definitively a stem cell transplant. On the other hand, secondary HLH is thought to be a polygenic condition caused by transient cytolytic defects with a later onset. You may see some of these in your adult patients as well. In these cases, the triggers are often identifiable. Most patients have it once in their lifetime, and the condition is less severe, and the treatment is different from primary HLH. What do I mean when I say that these patients have a cytolytic defect? The essential or underlying problem is an inability of the host, that's the patient, to kill targeted cells and turn off the inflammation. When we think about triggers for HLH or MAS, think of it in three broad groups. If you have a hyperinflamed patient in front of you and you're considering HLH, the triggers may be considered as rheumatologic triggers, infectious triggers, or oncologic triggers, especially lymphomas and leukemia. When the trigger is a rheumatologic condition, these patients are often termed MAS. And indeed, this is also seen in your patients in Pakistan from this very lovely single-center study from Dr. Saira, which looked at about 800 patients with lupus and showed an incidence of MAS in these patients at about 5 to 6%. So I am sure these patients exist here as well. Sometimes I find it helpful, instead of thinking of primary and secondary, to think of this spectrum of patients, or to think of these patients as a spectrum. On one hand, you may say that a patient with severe sepsis looks like MAS or HLH. And really, the clinical syndrome results from a combined effect of either the exogenous trigger and a genetic predisposition, with differing weights from these two triggers depending on the patient's age and underlying genetic abnormality. So if it's confusing, I would say it is more helpful to think about cytokine storm syndromes as a family of syndromes marked by hyperinflammation and multi-organ disease. And this umbrella term really encompasses a lot of clinical presentations. Again, remember, the problem is uncontrolled, which is dysregulated immune activation, resulting in excessive circulating cytokines, causing hyperinflammation. Although the two patients I presented to you were outpatients, if left untreated, very often the hyperinflammation can be fatal. You may see some of these patients in your pediatric or even adult ICU. What's the difference? I know some of you here are adult physicians, adult rheumatologists. Well, firstly, familial or genetic primary HLH is more common in children. If they have that genetic defect, without treatment, they don't often survive into adulthood. When we think about secondary HLH, in children, the trigger is more often infection, whereas in adults, malignancy is the more common trigger. As a result, for secondary HLH, the mortality rates in adults are higher because of that underlying trigger. This review by Nigrovich et al. Again illustrates what I just said. In looking for triggers, blue, pediatric, infection is the largest trigger, whereas in adults, pink, malignancy is the largest trigger. I hope that if you look at the purple, you see that it doesn't mean that adults do not have genetic predispositions. They may have it, it's just a lot less common than in a pediatric patient. I hope I've convinced you that, MAS and HLH exists and needs to be treated, but how do you actually make the diagnosis? Many times people say, let's look at the HLH 2004 criteria. I want to remind us that these criteria were created for a clinical trial on the treatment of HLH and have many limitations. First of all, these criteria are more reliable for primary rather than secondary HLH, and so no one criteria is really very helpful. In these criteria, the ferritin cutoff was 500, and that's not very high and not specific for HLH. These criteria also mention the presence of hemophagocytosis on a bone marrow exam, but not all patients get a bone marrow exam. And even if they do, the absence of hemophagocytosis does not mean the patient does not have HLH. There are other scores available if you're thinking about MAS and HLH. I deliberately put them very small because I'm going to admit I don't remember any of them at all. Firstly, there are limitations to the criteria, and I'm going to encourage you that as a careful clinician who can recognize HLH and MAS, you are more valuable than someone who remembers the criteria. If the criteria helps you to think about HLH, by all means use them. But because the patients we are treating are complex, it helps to develop a feel for MAS rather than memorize the criteria. In other words, I want us to smell the fire, even if it's coming from a matchstick, before it explodes into a humongous explosion. So what are the clues? Some people think of it in terms of 3 Fs. A patient with fever, falling counts, that's relative cytopenias, and a very high ferritin. The other thing that is unusually falling in such patients would be an ESR. In a very inflamed patient, you expect an ESR to be high. But in these patients, the ESR tends to be low. The other thing is to think about a patient who's acutely unwell with features that are not characteristic of the course of the disease in question. The example would be the lupus patient with severe pancytopenia, which is not quite typical for the lupus patient that you might be used to seeing. Okay, if you're starting to think about HLH, what can you test? This table lists for you some of the most useful and easily available tests on the left-hand side. And in the middle column, I give you the reason why these tests are high or low. The good news is most of these tests will be available even in resource-limited settings, and the turnaround time is very quick. I want to make a few points on ferritin. I've mentioned that ferritin is a very important and useful marker when you're considering HLH, but I want to remind us that it's not very specific. In patients with multiple blood transfusions, if they are post-transplant, stem cell transplant, if they have renal or liver dysfunction, malignancy or an infection, ferritin can be high as well. So really, if it's so non-specific, is it that helpful? I will argue yes. One thing you can look at is the level of elevation of the ferritin. When you're looking at a ferritin of a few thousands, think hard about MAS. And definitely when we're reaching levels of more than 10,000, like in the first patient that I presented, this is highly suspicious for HLH and MAS. So the specificity of a test is also dependent on the level of elevation. I have one slide on CNS HLH to remind us that sometimes HLH may not present as a systemic symptom or syndrome, but sometimes can be quite organ specific. In a patient presenting with seizures, irritability, disturbance in conscious level, encephalopathy, or even focal neurologic signs with no other clear etiology, start thinking about CNS HLH. In such patients, the CSF will show pleocytosis and a high protein. If an MRI brain is available, you may find multifocal and bilateral abnormalities on the T2 weighted images. The important thing about CNS HLH is that this can happen without systemic inflammation, which just makes things more complicated, right? I just said, think about HLH when the patient is systemically inflamed, but if that inflammation is limited to the CNS, it gets a little bit more complicated. But in many, many cases in rheumatology, the first step is to start with awareness, which will then prompt us for further evaluation. On this slide, I just present what other tests might be available for HLH. I think these tests are unlikely to be easily found in resource-limited settings, and even in Singapore, I don't get to do them very often. Good news, you don't need these very often to treat the initial HLH. Now, after diagnosing HLH, the next important step really is to look for the trigger. I said that the triggers can be thought of in three big groups, right? Infection, malignancy, or rheumatologic conditions. Most commonly systemic JIA, SLE, sometimes JDMS. The younger the child, the more we must think about things like inborn errors of immunity or inborn errors of metabolism. Here are some examples of the tests that you might do if you're thinking about specific triggers, and definitely how you test will depend on the patient as well as the epidemiological factors of the patients you're treating. But why? Why think so hard about triggers besides the fact that sometimes you have to treat the triggers? The reason for this is because pathophysiologic considerations guide treatment decisions, and I hope to show you or explain this more in the next few slides. Now, if you think about the different triggers, the mechanisms of inflammation are a little bit different. In sepsis and infection, most of the time there is innate immune activation, not so much T-cell proliferation. In MAS, meaning when the underlying trigger is a rheumatologic disease, then think of it that rheum disorder has created an already inflamed environment. In the case of SJIA, which is the most common rheum trigger of MAS, there's upregulation or there is increased cytokines IL-18 and interferon gamma. In EBV-related MAS, there's robust clonal T-cell expansion. In primary HLH, remember, cytolytic defect. In malignancy, the driver is the malignant cells. And in chemotherapy or CAR T, there are a host of cytokines involved. Now, keeping that at the back of your mind, it changes a little bit the first line of treatment or what you would push for treatment. If the trigger is sepsis or infection, besides treating the infection, first line therapy is often steroids, IVIG, and anakinra. If the underlying condition is systemic JIA, for example, sometimes the steroid doses need to be higher. You would use anakinra more easily and more readily. Cyclosporin is also very useful when the trigger is an underlying rheum disease. And I leave the other examples here for your reference. The other way of thinking about HLH is to think, what am I really targeting when the patient is inflamed? If we want to target cell proliferation, steroids, etoposide, ATG, cyclosporin are useful modalities for treatment. Whereas if you are pretty certain, based on what you think is the trigger, that the cytokines are IL-1 or interferon gamma, then the treatment options expand to JAK inhibition or anakinra. This brings me to the finesse of firefighting. If you think of HLH MAS as a fire that needs to be controlled, then you also need to think about what this fire looks like. If the trigger is cancer, you need to kill the beast, right? And in such cases, Dexa and prednisolone, which is a panacea for cellular fire, is useful. It's like dumping a whole lot of water on the fire. When infection is concerned, anti-IL-1 in the form of anakinra is useful and in some ways quite gentle. Etoposide is more focused on T cells. It's like aiming a water hose at the source of the fire. Also very powerful, but way more directed. Cyclosporin is also good, but the action is slower. A gentle hose rather than a shocking shot out of the fire hydrant. Practically speaking, I find this consensus-based guidelines very useful. Again, they have divided MAS into the following, right? Think of it in primary or familial HLH, secondary HLH, in children mainly infection, MAS, meaning rheum condition triggered, or malignancy associated HLH. In this article, they recommend that primary HLH is treated per the HLH 94 protocol, whereas in secondary HLH, remember, often triggered by infection, think about steroids. In mild or moderate cases, in MAS, you can see that besides steroids, anakinra and cyclosporin are high up in the consideration for what to treat with. Finally, for malignancy, etoposide is often very helpful, just as etoposide is very helpful in secondary HLH that is very severe and refractory to prednisolone and anakinra. This slide is here for your reference, as it contains steroid doses as well as IVIG doses. This is a summary of what is available. And again, doses and how fast you use the therapy is dependent on the patient in front of you. This slide again here is for your reference with regard to dosing of the drugs. I will not go into these further. Now, I think Prof. Sumara Farman told me that anakinra is sometimes available, and I want to provide some practical tips for using it at MAS. I want to encourage you that anakinra is safe, even in the setting of infection. So even in a child where sepsis is the trigger of the MAS, use anakinra early. If the trigger is SJIA, the dosing is higher, up to 10 milligrams per kilo per day. The usual dose for anakinra is 1. For MAS, anakinra works best with high-dose steroids. It works quickly, and you can expect improvement in 24 to 48 hours. If there is none, increase the dose, add steroids or another immunomodulatory agent. Rarely, anakinra can cause problems with LFT and eosinophilia, so if you are using that for longer than a period of a week, please look out for these side effects. Canakinumab is another anti-IL-1 agent, but somehow it's not as effective for MAS as anakinra. With that in mind, let's go back to the 2 cases that we started with. I want you to think, what would you start for these patients? Remember the 9-year-old girl with SJIE and MAS? Once we started treatment for her, her fever came down and she improved. What would you start? I know that a lot of times treatment decisions are also dependent on what's available at the time. For this girl, she got anakinra 100 milligrams, and thankfully, in the course of the treatment of her condition, she avoided steroids altogether. How about this girl, the 11-year-old with SLE and MAS? As you can see, we used ferritin as a marker. Because she had active lupus, she got her pulse solumedrol, which lysed the fever very beautifully. But the ferritin continued to climb. And at that time, again, considering that the diagnosis was lupus, I started her on intravenous cyclosporin, and she responded beautifully. Because her MAS was a shorter term condition than the lupus, she came off cyclosporin in a few weeks to a few months, and it was maintained on the usual lupus medication. Now she is 7 years post-diagnosis of lupus and remains only on hydroxychloroquine. So though the initial diagnosis of MAS may seem severe, treated early and properly, the outcomes can be really good. I'll leave you with one last case, which might be familiar to you. A 16-year-old boy with dengue shock syndrome. He was confirmed to have dengue on day 4 of illness. But the problem was, on the 5th day, he got more sick, increasing lethargy, abdominal pain, more petechiae, and hypotensive. His platelets were very low at 12. I think that's 1.2 lakhs. He was fluid resuscitated. He was given platelets and fresh frozen plasma because he also developed hematochezia. And here's his temperature chart at the top row. On the 7th day, which is a little bit unusual to have a persistent fever, he continued to be fiercely febrile and worsening in his clinical condition. Here are his lab investigations. You can see a worsening transaminitis with an ALT of 900 and an AST of 2000 and a high LDH. And his ferritin was very high at 33. So this patient was in the ICU. The patient was referred to oncology, who said, thankfully, okay, he does not need to fulfill HLH 2004 criteria. Well done, right? That criteria is not applicable to a boy with dengue. But there recommendation was to continue supportive management and can consider starting steroids. Thankfully, I think the rheumatologists in my institution have a good relationship with the ICU, and the ICU said, so when do we start steroids, right? The oncologist said, can consider. When do you start? So in addition to referring to oncology, they referred this patient to rheumatology, and we are happy to look at small fires, and we love treating small fires before they become big fires. And so once the referral was made, we gave therapy, his fever came down, and his counts came up beautifully, and his ferritin took about 48 hours to resolve. What would you have started for this boy? Well, in this case, we gave him a small pulse of IV steroids, and as you can see, he did respond beautifully. And because the trigger was an infection, and because he was older, which means the risk of a primary HLH is very low, he recovered fully from this and was off steroids within 3 to 4 weeks. So finally, I just want to mention some general treatment considerations when thinking about a patient with HLH-MAS. Remember, treat early, even if they don't meet criteria. If you're not sure, consider empiric modulation as long as the patient in front of you is showing severe worsening inflammation or organ dysfunction, even if you cannot find the trigger. In such cases, steroids, anakinra, IVIG are very, very safe. You don't have to follow the HLE guidelines. If there are rapid response to treatment, reduce your treatment rapidly. If there's no response, add something or increase the therapy you're using layer by layer. And where possible, refer to rheumatology early. But I hope after this, you also have some courage or confidence in treating. How fast should you expect response to therapy? In the very sick patient, you should be assessing them, including repeating blood counts every 12 to 24 hours. Once treatment has started, if it is working, expect stabilization in 24 to 48 hours. What can you see first? Ferritin often comes down quite quickly, but the first thing would be the normalization of the temperature. And of course, stabilization in terms of the blood pressure and organ dysfunction. How long do you give them immunomodulatory treatment for? Treat until inflammation is controlled, remove one medication at a time, and think about the trigger. Again, like in the boy with dengue, knowing that the trigger is self-limiting, I had confidence to know that he would not need immunomodulation for very long. This is quite different from the girl with lupus, who even though the cyclosporin could be withdrawn in weeks to months, she would continue treatment for lupus for many, many years. Remember that some of these patients will enter the ICU, and supportive care is vital and part of the treatment of their MAS. In summary, for MAS and HLH, remember it's really a spectrum of related diseases. The scoring tools, though useful, do not replace clinical judgment. Ferritin is a good and readily available biomarker. Treat early and calm the storm. Individualize the treatment, namely the type and speed, to the etiology and the severity of the syndrome. And when in doubt, steroids and anakinra are useful, helpful first-line therapy. I have 3 more minutes, and I will talk about difficult JIA. Now, this is a difficult topic because it is so patient-dependent. I will give one case example of a 7-year-old girl who was seen in my clinic after being referred by orthopedics for right ankle and right elbow pain and swelling. And she'd been having these symptoms for about 4 months. She didn't have pain or morning stiffness when you asked her, but the parents said it was definitely swollen and sometimes she does complain of pain. Now, the summary of this timeline is just to show that her first symptoms started in June 2022. She came to the clinic, got well after NSAIDs, and seemed to get well without no symptoms for a good 6 months, but would come back again to the room clinic for new joints being involved. Because she was very systemically inflamed, I think all of us were confident of treating her as for an inflammatory arthritis. Like Dr. Tash mentioned, these patients should be screened for uveitis even if they don't have symptoms, and she did not have uveitis. With treatment, including methotrexate and steroid injection, she continued to be just quite unwell. She came to the clinic saying that she was dizzy. She didn't have a fever. The ultrasound abdomen to look for inflammatory bowel disease was negative, but she was unwell. About 2 years after the first presentation, she developed intermittent fevers. A repeat calprotectin screen was done, which showed that it was high. If you look carefully, her inflammatory markers are very high, which are unusual for someone with just a few joints involved. Also, it was concerning that her growth started to falter. And so this was like a difficult JIA, started on adalimumab, but still not doing well. In addition, she had systemic inflammation and faltering growth. Her final diagnosis really was Crohn's disease, presenting for about 1.5 years before the Crohn's symptoms with polyarthritis. So in summary, if you think about a difficult JIA, meaning difficult articular symptoms, just let that be a prompt to reevaluation of the diagnosis, especially if there's systemic inflammation. Think about other systemic disease like inflammatory bowel disease. But let's say you are certain this is JIA and the joints are difficult, what can you do? I give some recommendations or suggestions. Targeted joint injections. To the adult rheumatologists here, I want to give you confidence to use higher doses of MTX. The adult rheumatologists are used to using 7.510. In the pediatric patient, we usually use up to 1 milligram per kilo per week to a maximum of 25 milligrams a week, splitting the dose to twice in a day of the week. For RF positive JIA, like Dr. Tash mentioned, anti-CD20 therapy may also be useful because they behave like a rheumatoid factor arthritis. Finally, leflunomide and sulfasalazine can be useful, and I've given the doses here. And where resource limitations are severe, perhaps some of these patients will need chronic steroids, but please aim for a dose of less than 0.15 milligrams per kilo per day. My last slide is on bad JIA uveitis. Assuming this child has bad uveitis despite adalimumab, here are some 3 things you may use. Optimize the methotrexate, increase the dose beyond regular doses for JIA, or consider tocilizumab, especially if there's cystoid macular edema. With that, I thank you.
We are thankful to the both speakers, and we have enjoyed the session with wonderful talks. And now we have a question answer from both the speakers. And my first question is by Dr. Abrar Ahmed. And he had asked Professor Tash, yes, please take the mic, please. And he had asked the common scenario of screening for tuberculosis in a patient who is going to be on the treatment for JIA. So what do you suggest is screening for tuberculosis before starting the treatment of JIA?
Latent tuberculosis?
Latent tuberculosis.
So tuberculosis, I just came back from India. I know that the chance of reactivation, their number is 3.4 to 10% when you use anti-TNF. So normally before you use, you have to screen, okay? For us, if possible, you screen both quantiferon releasing assay and then the skin test, also to capture the non-tuberculous mycobacterium by the skin test. But if the patient is already on a steroid or DMARD, the skin test may be not accurate. Then you end up with the APLAR once a year. Usually we do routinely once a year, regardless whether you have symptom or not. That's a screening for TB. After you take the any DMARD, actually, even methotrexate, people still recommend that you should do if you are in the endemic area, like India and Pakistan. Is that answer the question? Yeah.
I'll just interpret that. So sorry, he's saying so since we get the BCG and Montu is useless, so we all need to screen patients with at least a T-spot, quantiferon gold before starting. Even things like methotrexate can reactivate tuberculosis in endemic countries, and steroids as well. So not just for biologics. So we should be screening wherever possible.
The second question is for Dr. Ang. and this is by Dr. Fazaila. She wants to know what further treatment options are available for treatment of for treating if anakinra and IVIGs are not available. I think she's referring to MAS.
Yeah, so definitely first-line steroids, and if anakinra and IVIG is not available, cyclosporin is very helpful. In the last few years, there has also been increasing evidence for JAK inhibition, and most of the studies are for ruxolitinib, but if that's not available, I think tofacitinib is reasonable.
So we use a lot of cyclosporin, and if it is MAS in the setting of lupus, then rituximab is an option.
And second question from Dr. Ann again. This was asked by Professor Christensen. What's the role of the lipid profile in the prognosis of the MAS?
Lipid profile.
Is there any role of lipid in the prognostic?
So, I mean, one of the criteria for MAS would be a high triglyceride level. I'm not aware of any prognostic information from that. When in doubt, a high triglyceride level is nice to have, but I think when you develop a field for MAS, it's not really necessary.
So the next question is for Dr. Tash. Dr. Tash.
Yes.
Right, and this is from Dr. Saira, who is a PG trainee at Fauji Foundation Hospital. And she wants to know why you recommended X-rays to monitor joint damage. Isn't ultrasound a more sensitive modality to detect early erosions and a safer one too?
Yeah. So as I mentioned, our APLAR guideline geared toward limited resources. X-ray everywhere has it, including this morning clinic. They're going to have one. But the ultrasound is not available every single place, number one. Number two, it's very operator dependent. You need to get trained and do enough. Number three, ultrasound for kids is not easy either. Okay. It's not easy to read. Yeah. So these are the reasons. If you have ultrasound and you can do it, that's actually, to me, is better because you can see earlier. Yeah. X-ray obviously delay, but then at least if you see the X-ray, it's there.
Yeah, so basically, because these guidelines have kept in mind the less resourced countries in Asia Pacific, and not musculoskeletal ultrasound is not available everywhere, and it's very dependent on the expertise of whoever is doing it. And X-rays are usually available, so that is why, prognostic value of if you see erosions, you need to be a little more aggressive, and that's what he was saying. I mean.
So do we have time for one more question? This is also for Dr. Ang, and this is by Dr. Rabia Batul. In MAS, secondary to GIA, what's your first line and second line management? How do you sequence steroids, cyclosporin, anakinra, and tocilizumab?
This is for MAS and systemic GI?
Secondary to GIA.
Yeah. So if anakinra is available, I would use that. But let's say most of countries in this region not available, I would definitely use steroids. And in rheumatology, treat hard and fast. I would pulse with steroids, and very often they get better. You can start at 10 to 30 per kilo for a pulse for 3 days. And if after that they're better, you can get them on steroids, oral 1 to 2 per kilo per day. But don't forget that the underlying systemic JIA needs to be treated. And in this case, steroids may help that, but not useful long term. So tocilizumab, methotrexate if there's strong articular component.
And how commonly you encounter after influenza episode the trigger to MAS?
Influenza, yeah, we definitely see influenza cause MAS, but when I see a viral trigger, I feel very happy. I know they're going to do well with a short course of steroids, and if they're not the very young child, meaning I'm not afraid of primary HLH, these children will do very well. Yeah.
Thank you very much. We had a very pleasant session. And
one last question, Dr. Ang. So tocilizumab is also linked with the development of MAS. There are certain studies. So what is your take on that?
Yeah, and not just tocilizumab and MAS, but tocilizumab and ILD is a big debate, especially in North America. I think in Asia, whether from China or Japan, where systemic JIA plus minus MAS is high incidence, we're not seeing that. So I would not be afraid of using tocilizumab. Don't let that stop you from treating the MAS.
So some experts think that it is not effective enough to control as in compared to IL-1 inhibitors. In case you don't have IL-1 inhibitors and a patient is not on tocilizumab, you can actually use it for MAS treatment. Yeah. So I think this is the last question. Yeah.
I'd now like to request Professor Nighat Mir, Patron-in-Chief, Professor Sumaira Farman Raja, Chair of the Scientific Committee, and Dr. Ahmed Said, President and Convener of PSR, to please come on stage and present a token of appreciation to our Chair, Dr. Taqdees Khalik. We also extend our gratitude to Dr. Muhammad Shahid, who has already received his token earlier, so we won't ask you to come up again.